So this is an ALS update, and I tried to make it as current as possible, and hopefully you'll be convinced that we are really making some progress here, and there's signs of some real hope. So all of us in this field, we want the same thing. We want a cure for this disease. And it turns out, in my opinion, there's only 6 reasons why we don't have that cure yet. First of all, we don't know what causes most cases of ALS. Second, we don't know if this is one disease or many. Third, we don't know why once people get this disease, they can't just shake it off like they do the flu. They just keep getting worse. Next, it takes a long time to make a diagnosis of ALS. On average, about 14 months between symptom onset and diagnosis. And in that period of time, people lose about half their motor neuron pool. So by the time we can say that somebody has ALS, they've already lost about half their motor neurons. If we're trying to save motor neurons, we got to find a way to diagnose it faster. Next, the tools that we have for measuring ALS are very noisy and slow to change. And as a result, when we do clinical trials, we need a lot of patients. And we need our trials to go on for a long period of time to know if we actually did anything. And then finally, and most surprising of all, enrollment in ALS research studies is lower than you'd expect. So I think we're finally starting to make progress on these 6 barriers. That we're finally starting to get to a point where we can see the top. So first of all, in terms of what causes ALS, well, we now know that there's at least 2 types of ALS, distinguished by cause. First of all, there's something called familial ALS. That's about 10% of everybody who gets this. Classically, that's defined as inheriting a disease-causing gene. And as of today, there are more than 20 different genes that we've identified, each of which can cause ALS. And you can see here that the rate of discovery in terms of disease-causing genes is just exploding. So this graph shows the number of different disease-causing genes across time. And you can see here that for many years, we only knew about 1 gene that could cause familial ALS, SOD1. And just in the past few years, things have exploded. This is because we have new technologies now, which are based on chips that allow us to look at a huge number of genes at the same time. And these have become a lot less expensive. There is one gene I just wanted to point out, because I'll be mentioning it again. It's called C9orf72. That gene explains as much familial ALS as every other gene that we've ever discovered combined. So it is the single most common identifiable cause of ALS, C9orf72 mutations. So why is all this genetic stuff important? Well, because we can now use it to build animal models of ALS. So we can insert abnormal genes into mice, rats, flies, worms, and fish. And we can look at these very carefully and try to understand how the disease is progressing. What molecular mechanisms is the disease using to progress? Each of these models has advantages and disadvantages. For example, flies are very inexpensive, but you need a tiny reflex hammer to get their reflexes on exam. I'm just kidding. We don't check reflexes in flies. So there is another category. It's called sporadic ALS. That's what 90% of people have. Now, the distinction between familial and sporadic ALS is starting to get a little fuzzy. And the reason is when we do some of these new powerful genetic tests in people that don't have a family history of ALS, sometimes we find that they have a disease-causing gene. That happens in somewhere between 1% and 5% of everybody out there with ALS who does not have a family history. So the total percentage now of people with genetic ALS is about 12%. And the people with non-genetic ALS is about 88%. So how do people with non-genetic ALS get the disease? Well, even there, we think there's a role for genes. We think you have to have at least 2 hits to get the disease. You got to have a susceptibility gene or multiple susceptibility genes, and you've got to get an environmental exposure or exposures. So we have 2 different ways of looking for susceptibility genes. The old way is called a candidate gene approach. This is where we would pick a gene that we thought might be involved in ALS, and we would see if it looked different in people who had the disease compared to people without. So for example, PON, P-O-N, that's a gene that codes for a protein called peroxinase. And the purpose of that protein is to help us get rid of toxic chemicals like weed killers and pesticides. And it turns out that multiple studies have shown that some people with ALS have a different form of PON compared to people who don't get ALS. So they may be more susceptible to those chemicals, and that may be part of the reason they get the disease. But you can see we've identified several different things through candidate gene approaches. These are the genes in red. So at least 4 genes that several studies have shown to be abnormal. One of the problems is that not every study shows the same thing. So although there are several studies that show that people with ALS have altered PON, there are several other ones that don't find the same thing. So I told you before, we've got these new genetic technologies where we use chips. And instead of just looking at one gene at a time, we can look at all the genes. And we could say, what's different about all the genes in this group of people with ALS compared to people without? And those are very expensive studies. And we found some genes that look different in some of those studies. But sadly, we didn't find any of the genes that were identified in the candidate gene approaches. And also, those studies don't seem to be replicating each other every time either. So at this time, there doesn't seem to be one overwhelming susceptibility gene for people with sporadic ALS. What if we look at the other side of the equation, the exposures? Well, there again, we have 2 ways to look at exposures. So we can look at something called clusters. A cluster is either a place or an occupation where there's a lot more ALS than there should be. That can give you a clue about an environmental trigger. So the most famous cluster once upon a time occurred on the island of Guam, which I'm going to talk more about in a minute. There's also a cluster in military veterans. So veterans are about twice as likely to get ALS as non-veterans. That's actually a very important cluster because if you're a veteran with ALS, there's a tremendous number of benefits that are available to you that are not available to non-veterans. So unfortunately, just as with the susceptibility genes, these studies looking at environmental exposures don't seem to be replicating each other very often. One study finds one thing, another study finds something else. So there's yet another way to look for environmental triggers, and this is through something called case control studies. So what we can do here is we can take a whole bunch of people that have ALS in one area of the country and compare them to age-matched, gender-matched controls, people without ALS from the same part of the country, and we can look backwards over their lives and we can say, what's different about these 2 groups? What might one of these groups have been exposed to that triggered the ALS? And there we have some really strange findings. So it turns out that people who get ALS are about twice as likely to have played a varsity sport at some point in their lives. So athleticism may be a risk factor for ALS. And also, people who get ALS, very rarely were they ever obese in their life. So lifelong slimness seems to be a risk factor for getting ALS. So I saw in the faces of a few of you that have seen me before, when I walked in, you said, boy, Bedlack's really letting himself go. And this is part of the reason why, you see? Oh, I should say, so why are these studies not replicating each other? Well, think about this for a minute. If there's more than 20 subtypes of familial ALS, there's probably at least that many subtypes of sporadic ALS, right? It's probably not just one sporadic ALS. So what I think is going on is you're going to have at least 2 hits. So for people who have PON polymorphisms that were the susceptibility, they've got to be exposed to enough pesticide to get ALS. If they weren't exposed, that's not a susceptibility gene. They never get ALS. So it's going to be very difficult to work this out, but there are some studies being done right now that are looking for interactions between susceptibility genes and exposures. I think those are very exciting. So before we leave this area, I just wanted to mention this because I think it's fascinating. So once upon a time on the island of Guam, there was a cluster of ALS. The people who lived there, the native people, which were called Chamorros, they were 50 times more likely to get ALS than anybody else in the world. And so people flocked to Guam because they thought the key to understanding the environmental trigger for ALS must be there. And when these people died, they did find a neurotoxin present at very high levels in their brains and spinal cords called BMAA. So the next thing they did is try to figure out where is that coming from. And the first place they found it were in these seeds that grew on palm trees called cycads. And it turns out that the native population of Guam did smash up those seeds and use them to make flour. And so at first glance, it seemed like that might be the answer. But then somebody did some calculations and said, no, a human being can't possibly eat enough of those seeds to get the levels of these toxins that we're seeing. So they went back to the drawing board and they figured out that these people also have a diet that is rich in flying squirrels. So the native people of Guam like to take those squirrels and make a special soup, squirrel soup. And it turns out that those squirrels eat those cycads and concentrate that toxin in their muscle. So if you eat those, you could get really high levels of that neurotoxin. And the other nice thing about that theory is that the risk of ALS on Guam in the past 20 years has just plummeted. And now the people of Guam are about 5 times more likely to get ALS. And what happened before that? The flying squirrels became extinct. They all got gobbled up. So that seemed to make a lot of sense. And we thought that was the end of the story until about 4 or 5 years ago when we were sitting at a meeting, and here came the last remaining epidemiologist from Guam with a long white beard and a straw hat up to the microphone. And he said, I'm still perplexed. If there haven't been flying squirrels in Guam for more than 20 years, why is the risk still elevated? And he found another source of BMAA, blue-green algae, also known as cyanobacter. And as he presented this, I mean, most of us in the room got the goosebumps, because all of a sudden what was happening on Guam became immediately relevant for everybody in the world. You know, outside of Guam, there's not a lot of cycad consumption. And outside of Guam and maybe West Virginia, there's not a lot of squirrel consumption. But blue-green algae is everywhere. So people went back home and they started looking in their autopsy banks at the brains and spinal cords of people from North America who died from ALS. And sure enough, a subset of them do have really high levels of BMAA. And then they started doing epidemiology studies looking at the risk of ALS around bodies of water in the United States that are full of blue-green algae. And guess what? It seems like it's elevated. So there's a lake in New Hampshire called Lake Muscoma, and the risk of ALS around that blue-green algae-filled lake is 25 times higher than any place else in New England. And it's twice as high on the downwind side of the lake as it is on the upwind side of the lake. So this looks like it's going to be a major environmental trigger for ALS. So there is an opportunity for every patient in this room now to contribute to our understanding of why people get ALS. It's called the National ALS Registry. It's free, it's easy to enroll, it's on your home computer. Hopefully everybody in this room with ALS has signed up for this study. One of the things I just heard about in Washington a couple months ago when I was there is that, well, a lot of people have signed up for the registry. Only a small percentage have answered the questions about their lives, which are called the risk factor surveys. So if it's been a while since you've been on the registry page, I would encourage you to go back on there and sign up for the risk factor surveys. This is how we're going to find out what the triggers for ALS are, by thousands of people answering questions about head trauma, electric shocks, toxic exposures, diet, things like that. So we talked before about how important the genetic model for ALS is. How could you model a disease like sporadic ALS where you don't know how it starts in the first place? Turns out there's a way. So now we've discovered a way to scrape the skin of people with sporadic ALS, take those skin cells and treat them with the virus and make them into stem cells. And then we can take those stem cells and turn them into whatever we want with the right chemicals, motor neurons or any of the cells that live next to motor neurons. And we can see how these cells behave in a dish. So for the first time, we've actually got a way to get cells from the brain and spinal cord of people with sporadic ALS in a dish to see what's different about them. And we're finding something very interesting. So this is work by my colleague, Dr. Brian Wanger at the Mass General Hospital. And all these graphs, the net result of all this is that the cells that come from people with ALS are hyperexcitable compared to the cells that come from healthy controls. They're firing a lot more action potentials. They're a lot more sensitive to any kind of stimulation that you put on those cells. And that may be part of the reason why they're dying, because they're so excitable. And there's a drug that's been used for the past few years for people with epilepsy, which is called Retigabine, also known as Ezogabine. And when you put that on these cells in a dish, you normalize their excitability, and you also dramatically improve their survival. So that's very exciting. And Brian is actually now opening up a clinical trial of this drug for people with ALS. So the Retigabine trial is going to be opening in the next month or two at several sites. We're going to be looking for 120 patients with ALS across the country, dividing them into 3 groups. 1/3 of patients get placebo, 2/3 of patients get drug, and there's 2 different doses of the drug. The study is 12 weeks long, and it does require several visits, during which we're going to be looking at a lot of different things, including the excitability of the brain and spinal cord using something called transcranial magnetic stimulation. So that's a really cool study. So the second issue is we don't know for sure whether this is one disease or many. So why would we think that? Well, this paper over here presented this graphically really nicely. There's a whole bunch of different ways that ALS and its variants can look. So here's a person who has upper and lower motor neuron disease that started in their arms or legs. That's called spinal onset or limb onset ALS. Here's a person that has upper and lower motor neuron disease just in their speech and swallowing muscles. We call that bulbar onset ALS. Here's a person that only has lower motor neuron disease in their arms and legs. That's called progressive muscular atrophy. Here's a person that only has upper motor neuron disease in their arms and legs. We call that primary lateral sclerosis. Here's a person with upper and lower motor neuron disease that only affects their hands and feet. Everything else is spared. Here's a person with upper and lower motor neuron disease that only affects one side of the body. It's called the hemiplegic variant of ALS. Here's a person with predominantly lower motor neuron disease that just affects their arms. And here's a person with predominantly lower motor neuron disease that just affects their legs. This is called the flail arm syndrome and the flail leg syndrome. That's a lot of different ways that one disease might be presenting. The other thing I would argue is that the progression rate is so incredibly different across patients with ALS. So here's 30 patients from a clinic. These are the ALS Functional Rating Scale scores. So the ALS FRS is a questionnaire that most of us use in our clinic to ask patients about functions in different parts of their body. There's 12 questions. Each question scored from 0 to 4. 4 is normal. So a normal score is 48 points. Most people with ALS drop by about 1 point per month on that scale. But you can see how variable this is. So these are the traces of the scores from 30 patients. Here's a patient who was hardly changing for many years, 6 years. Here's a person that didn't even live a year. They just plummeted. So tremendous differences in progression rate. Hard to think of how that could all be the same disease unless some people have modifiers. And there's starting to be some evidence that there are modifiers. There's genetic modifiers. So we have found 2 genes where there's variations that seem to go along with very slow progression. One's called KIFAP3, which is coding for a motor protein. The other one is FA4, which codes for a protein that regulates the interaction of nerves and muscles. So by understanding those a little bit better, we might get some clues in how to slow this disease down in everybody. There's also non-genetic determinants of progression. Turns out that people who have a higher body mass index, people who are heavier, progress more slowly than people who are lean with their ALS. People who have high serum creatinine don't do as well as people with low serum creatinine, and people with high uric acid do better than people with low uric acid. It's not clear what all that means yet, but another one of my colleagues, Sabrina Paganini at MGH, is using that uric acid observation to do a small pilot trial. So she's going to try a drug called inosine, which raises the uric acid level. What is uric acid? It's an antioxidant, like we were talking about before. Oxidative stress may be important in ALS. So maybe by using inosine to raise a person's own uric acid levels, you might be able to slow progression. So this trial is just about to start enrolling at Mass General. It's going to be a very small study of just 25 patients, 16 weeks, and you can see that everybody in this trial is going to get the drug. There's another group that I wanted to make you aware of. This is a group I belong to, which is called CREATE, C-R-E-A-T-E. It stands for Clinical Research in ALS and Related Disorders for Therapeutic Development. This is a group whose entire mission is to understand this variability in motor neuron disease, to understand why some people get ALS, some people get PMA, some people get PLS, why people progress at such wildly different speeds, why the disease starts in so many different places. And so they're going to be looking at the genetics of a large number of people with all these different forms of motor neuron disease, as well as looking for serum biomarkers. And they really want people who are interested in having blood tests to help them understand this. So you can Google, create, and you can find this right here, which is their Rare Disease Clinical Research Network Contact Registry. It's a place where you can go and sign yourself up if you're interested in helping us understand this variability, and they'll contact you to participate in future studies. Okay, so how does this disease progress? Why does it progress? Why can't we just shake it off? Well, in order to understand progression, we've got to look at the one form of ALS that we understand the best, and that's called familial ALS type 1. That's ALS that's caused by mutations in the SOD1 gene. And so SOD1 is a gene that codes for a protein whose function is to help get rid of free radicals. And so when we first learned about SOD1, I guess it's been more than 20 years ago now, the thought was, okay, this gene's mutated, it doesn't make a protein that works, free radicals build up and cells die. Sounded pretty straightforward. Unfortunately, that's totally wrong. What happens is that this gene, when it's mutated, it actually produces a protein which gains a new toxic function. How do we know that? Well, first of all, we can look across all the different mutations in this gene, and we can look at the specific proteins that are made and put those in test tubes, and most of those proteins get rid of free radicals just fine. Second, we can make a mouse model where we give it lots of extra normal SOD1, and as long as it has one copy of the mutant SOD1, it still progresses and dies from what looks like ALS. And then finally, we can make a mouse that doesn't have any SOD1. We can just get rid of that gene altogether, and the animal does not get ALS. So what is this new toxic function? Well, we still don't know for sure. There seems to be a lot of things that this new toxic protein can do. So this is supposed to be a motor neuron, and these are a whole bunch of different things that this toxic protein is doing inside the motor neuron. So one of the things it's doing is clumping. That's called aggregation. It's binding to something called microtubules, which are like train tracks that allow the cell to transport things up and down. And when it binds there, the cell can't transport things. It's binding to the power plants of the cell, which are called the mitochondria. And as a result of that binding, energy production is messed up in the mitochondria. Also, these become leaky, and toxic substances from inside the mitochondria leak out, and they cause the cell to want to kill itself in a process called apoptosis. These abnormal proteins are binding to something called the endoplasmic reticulum, which is involved in protein processing. And as a result, all protein processing starts to be messed up in the cell, which again makes the cell want to kill itself. So a whole bunch of different trials have been done to manipulate those events without great success. But then there's this one, which I personally think is the most exciting research study that's ever been done. I think this is the line of evidence, the line of research that is going to lead us to the first ever dramatically effective treatment for ALS. It's called antisense oligonucleotide technology. So this is a company with the unfortunate name of ISIS. And what they've developed, again, is a whole range of products that can block bad genes from producing bad proteins. And so they've got one for SOD1. It actually worked really well in the animal model of ALS. They've completed one very small safety study, 33 patients who had a single infusion of this into their spinal fluid. People seemed to tolerate it well. It had really good pharmacokinetics. And I think very soon, probably within the next year, you're going to see the first large-scale trial of this. And again, I'm very hopeful that this could dramatically slow or maybe even stop the progression of ALS for people who have SOD1 gene mutations. So all those things that I showed you, all those events that we're trying to block, they're all happening inside motor neurons. Now, of course, we'd be focused on what's happening inside motor neurons because this is a motor neuron disease. Well, there's been some research in the past few years that tells us that if we want to slow progression, look at inside motor neurons might be the wrong idea. So there's a new way to build animal models now, which is just amazing. You can build an animal that has every cell in its body mutated except one type of cell. You can genetically rescue one type of cell. So you can build an animal model where you genetically rescue motor neurons and leave every other cell genetically abnormal. That's exactly what we've been trying to accomplish with all those drug studies. And guess what happens? Absolutely nothing. Genetically rescuing motor neurons does not do anything to help the animal. It still progresses and dies from what looks like ALS. On the other hand, if you genetically rescue cells that live next to motor neurons, especially some of the immune system cells, you can dramatically slow the progression of ALS in these animals, in some cases for months. Now that might not seem like much, but the best drugs we've ever studied in these animal models prolong survival by days. And we think that translates into months in people. So if you could prolong survival in these animals by months, that might translate into decades of extra survival in people. So there's been a lot of research trying to manipulate different parts of the immune system. I told you about this very briefly in the last session. A company called Neuraltis has a drug called NP001. It's an intravenous drug, and what it does is it blocks the activation of a type of cell called macrophages. And again, they did a small trial, 136 patients, 3 groups. 1 group was placebo, 2 groups of different dosages of this. And they did this responder analysis where they showed that people on the highest dose of this drug had a much more likely chance of not progressing for 6 months compared to people on placebo. It's very exciting for 2 reasons. One, you know, that may be a large effect size, lack of progression. That would be nice if we could stop progression. And 2, this might be the first study that actually finds a subset of people that respond to a drug, which I'll talk more about in just a minute. There's another trial that just finished that also manipulates the immune system. It's called fingolimod. And again, this was a study that was first done in animals, and it was shown to work. A small 30-patient placebo-controlled trial was done at Mass General Hospital. It's finished, but we don't have the results yet. I would look for those by the end of this year. And then finally, we get to one of my new programs, which is called ALS Reversals. So what if instead of really understanding how progression works and manipulating it at the molecular level, what if we could just say, well, I know people with ALS progress, and if somebody has the exact opposite course, maybe we should study the heck out of that particular person to see if we can understand what happened. Even if we don't fully understand it, maybe we can give other people exactly what that person tried and make other folks better. So people who get better from their ALS, I call those ALS reversals. And at the helm of ALS Untangled, I told you about Nell DeBoos, and I also told you about Mike McDuff, whose records I have. Well, I have the records of 13 other people that I've found that I'm absolutely sure have ALS, and I'm absolutely sure they're getting better. Not just slowing down in terms of their progression, but regaining things they've lost. Some of these people are in clinical trials. So these graphs are from a paper on a clinical trial of something called NeuralStem. NeuralStem is a company that believes that embryonic stem cells are the way to go. And they're transplanting these into the spinal cords of patients with ALS. So you have to go to the operating room, have your spinal cord opened up, and have these injected in with a needle. And then afterwards, since they're not your cells, you have to have immunosuppression, the kind of immunosuppression they use for people who have organ transplants. And these are the graphs of some of the people in the study. And you can see that there's an ALS reversal here. So the purple trace that's present in all these graphs is a patient who was progressing pretty quickly before they got the stem cells. And then afterward, they had a dramatic improvement, and they stayed well, really, for the rest of the study. Just about anything that they measured, grip strength, ALS, FRS, all these things improved in this patient. So I think that's very, very exciting. Now, this is not usually the way we study progression, as we've talked about. Normally, we study progression in cell models or animal models, but you know, I think it's important to keep doing that, but we also have to at some point say, we've been doing this for 20 years. We've been looking at these models for a long time, and we haven't really found anything that helps the model that works in people. So maybe it's time to think outside the box a little bit, try something different. And it turns out there's a precedent for discovering something amazing by focusing on a group of unexpected responders, and it comes from the HIV world. So we've known for 20 years that there's a population of people who get infected with HIV, never take any medications for it, and never get sick. They're called elite controllers. And for many years, people just shrugged their shoulders when you asked about those folks and said, I don't know what's going on with those people. But finally, somebody put them all in the same database and got blood samples on them. And it turns out that a lot of these people have the same genetic abnormality. The abnormality is called CCR5 delta 32. What it does is it changes a protein in the surface of all their cells called CCR5. It's a protein we didn't know about before, but that protein is really key for HIV to get into cells. It's like a keyhole that it has to use to open a door for the HIV to get in. And because of the abnormality these people have, HIV cannot get into their cells. So by studying this strange group of atypical responders, they learned something really important about the biology of this disease. And Pfizer took this information and developed a drug that blocks that receptor that works for everybody with HIV. It's called Marivoc. So maybe we can do the same thing for people with ALS. First thing we have to do is figure out how to define an ALS reversal, so we're all talking about the same thing. And so I worked with my colleagues at Mass General Hospital and at Patients Like Me, and we looked within that big PROACT database that I told you about before. Largest database available of people with ALS, people who participated in 17 previous trials. All their information was put in one place. So there's long stretches of data on patients. And what I asked these folks to do is tell me the percentage of people in this database who have periods of time when they change by different amounts. So the blue trace here is a percentage of people with a 0-point change in their ALS functional rating scale, lasting different amounts of time. So it's not at all unusual for people with ALS to have 30 days when they don't change at all. But it's very unusual for people to have 360 days where they don't change at all. These other graphs are different levels of change: a 1-point improvement in the scale, 2-point improvement, 3-point improvement, and 4-point improvement. And so the net result of all this is that we've decided to define ALS reversals as patients who have at least 4 points of ALS-FRS improvement lasting for at least a year. So we think that definition is robust enough to be important, but still allows us to have enough patients to study. About 1% of all the patients in the PROACT database have an ALS reversal at some point. That's about the same percentage of people that are HIV elite controllers. And if they could do it, maybe we could do it. Maybe we could figure out what's happening in these folks, make it happen more often. So if you're going to study something, you got to have hypotheses for why it happens. And I think there's 3 possible reasons why a person's ALS might reverse. First of all, maybe they didn't have ALS in the first place. Maybe they had something that was so closely similar to ALS that even an expert couldn't tell it apart, an ALS mimic. Second, maybe their body has figured out a way to beat ALS, like those HIV elite controllers. And third, maybe these people have actually found things that work for ALS, and we should pay attention. So I've got 2 separate research programs designed to investigate these hypotheses. The STAR program is the study of ALS reversals, where I try to figure out why it happened. The R.O.A.R program is the replication of ALS reversals, where I try to make it happen again in more people. And I told you in the last segment that the first drug I'm going to study in the R.O.A.R program is Lunasin. So we did talk a little bit about this, that this is something that alters histone acetylation. And as a result, it alters the pattern of genes that are turned on in a person. Told you about Mike McDuff, how we got his records and we pored over them, and we do think he has a form of ALS called progressive muscular atrophy. It does appear that as of a year and a half ago, he had lost his speech and swallowing, and those have now come back on Lunasin. He's not the only one. So since I became interested in this, I've received a lot of reports, often by email or Facebook, of people that are trying Lunasin and experiencing at least some benefits. So I have 13 people now that are reporting what sound like dramatic benefits from Lunasin. Unfortunately, don't have their records to be sure that they do have ALS or that these benefits are real. Again, this is something that appears quite safe. Can't really find any evidence of any serious adverse events. And the one downside is if you decide you want to take Lunasin and you want to do it exactly like Mike McDuff did, it's pretty expensive. It's about $700 a month. In our trial, we've made a deal with the company. The company's actually going to supply these products to people in our trial for free. So I'll tell you more about the design of that trial in a later section of this talk. There is one other group that's also trying to replicate an ALS reversal, and it's actually the same group that did the neural stem study. So I showed you that one patient that was in the study that was having their ALS reverse. It may not be the stem cells that was making that patient get better. In fact, his improvement started very quickly after the cells were implanted, which is not what you'd expect. You'd expect it would take months or maybe even years for the improvement to start. So their hypothesis that maybe it was the immunosuppressive drugs that actually made that person better. Maybe they knocked down inflammation. So they're going to try the exact same cocktail of immunosuppressive drugs in more patients. And in fact, they have tried it. The study's done. But we don't actually have the results yet. Hopefully later this year or early next year we'll have those results. So now we come to trying to get over the barrier of delayed diagnosis as well as the barrier of noisy follow-up measurements. And I think the line of research that's going to help us with both of these problems is called biomarkers. So what is a biomarker? It's a measurement of a biological process. And ideally, it's a way to measure that process that's either easier, less expensive, faster, or more efficient than measuring the biological process the way that you currently do it. So there's a lot of different possible biomarkers. A biomarker could be an imaging study. It could be a fluid, a blood test, or a spinal tap. It could be some tissue. Or it could be a lot of other things, including even a questionnaire in clinic. There's a lot of examples of biomarkers being used in other fields that have revolutionized those fields. So one of the most common things that neurologists see is stroke. And we never had a reliable biomarker for an acute stroke. You know, CAT scans usually don't show a stroke for a day or two. If we want to know if somebody had a stroke within the first few minutes, we now have something called diffusion-weighted MRI. So you can see the bright spot in that MRI scan. That's an acute stroke, a stroke that just happened. Multiple sclerosis is another example. So there we've got biomarkers that actually tell us how bad the disease is. So those are all the white spots that you see in those MRIs. Those are all MS plaques. And you can use that biomarker to determine whether a treatment is working. And then finally, we've got in the cancer field something called a PET scan that looks for cells that are metabolizing glucose at a fast rate, which cancer cells do. And again, you can use that to determine if your treatment is working. You can see the two PET scans there. Clearly before treatment, there's a lot less hot spots than after treatment. So we're on the cusp of finally having biomarkers for ALS. And I think we're probably going to have a diagnostic marker for ALS within the next 1 to 2 years. So we'll have some way that we can be sure that a person has ALS, a test that comes back yes or no for ALS. And there's two types that I think we might have. First is an imaging biomarker. And that's going to be another version of MRI, which is called fractional anisotropy, FA. This actually allows us to measure the size of specific tracts in the brain. So the upper motor neurons are mostly concentrated in a tract in the brain called the corticospinal tract. Using MRI FA, you can look at the thickness of that tract. So Here is the thickness of a series of control patients. Here's the thickness of a series of patients with ALS. When you look at these with the naked eye, they don't look different. But if you ask a computer to subtract them, there's a big difference. The volume of those tracks in people with ALS is a lot less. There's also a company out there called Iron Horse Diagnostics, and they think they have found a fingerprint in the spinal fluid, a protein fingerprint that identifies who has ALS and who doesn't with really high accuracy. And so there's a study that's going on right now to see if they're right. So that study is open at several centers across the country and looking for people who want to participate. It only involves one visit, and during that visit you have to have a blood test, a urine test, and a spinal tap. In the meantime, we already have a biomarker that just recently came out that allows us to follow patients more efficiently. It's called electrical impedance myography, EIM. What it is a series of probes that are put on a patient's skin, and a small electric current is passed between those. And based on the thickness of the muscle, there'll be more or less resistance across that pathway. And so this is an electrical measurement of muscle atrophy. So what does this do for us? Well, the key to this slide is this graph right here. So if we use the ALS functional rating scale to do a clinical trial that involves two groups, we need to have 220 patients in each group, 440 patients in the study. If we do a clinical trial that uses EIM, we only need 95 patients in each group to be able to detect a difference. So it dramatically cuts down the number of patients, which means trials can be done faster with less resources, which means ultimately we get to the cure for ALS faster. And then last but not least, there are these things called pharmacodynamic biomarkers, which may be the most exciting of all, because these actually show pathways involved in the progression of ALS. So over on the left-hand side, that's a rat brain, not a human brain. And what it's showing you there is something called EAAT2. That's a transporter that's found in the membrane of cells next to motor neurons called astrocytes. And it's involved in sucking up a toxic chemical called glutamate. And we know in people with ALS there's not enough of those. On the right-hand side, you see something which is called a PET scan. And in this case, what they did is injected a person with a ligand that is only taken up by activated microglia. So it's only taken up by immune cells that are activated, that are involved in trying to kill whatever's around them. And what you can see here is A and C are PET scans from people without ALS, and B and D are from people with ALS. And there's a lot more activity of this cell type in people with ALS. So my colleague at MGH, Nazem Atassi, has taken this one step further. And he's actually done a lot of work, and he can now not only distinguish who has ALS and who doesn't, but he can even figure out from the pattern whose ALS is affecting their arms and legs and whose ALS is affecting their bulbar muscles. So this is really cool research. And it's going to revolutionize the way trials are done here in the next couple of years. And let me show you what I mean. So what we're going to be able to do is very short duration clinical trials where we take a drug and we say, let's just make sure that this drug actually works on the mechanism that we think it works on. So for example, NP001, something that's supposed to block the activation of immune cells. We can use this new assay, this new PET assay, and ask, does it actually block that mechanism? And that study can be done in a very small number of patients very quickly, in just a couple of months. And then what you can do is you can say, okay, now we'll take the most promising drugs that work on that mechanism and bring them into more traditional trials where we have lots of patients and we do the trials for long durations and see if they actually work. But this way we won't get to the end of a trial and the trial didn't work and we scratch our heads and we say, why did a trial not work? Was it because we didn't give enough? Was it because the idea was wrong? We didn't use it long enough? A lot of times we don't know the answer to that question. Also, these types of biomarkers are going to allow us to pick out subsets of people with ALS that might have different mechanisms that are causing their progression. And I definitely think this is going to be useful. So you might be able to take a whole bunch of people and do this PET scan on them and figure out which ones have ALS getting worse because of overactivation of their immune system. And those would be the ones that you would select for a more traditional clinical trial. You wouldn't just take everybody, only the people that have that mechanism at work. So then last but not least, we get to what I said before, I think is the most surprising of the 6 barriers to a cure for ALS, and that's this enrollment barrier. We talked last time about this low enrollment rate of 2 patients per site per month, and only about 5% of people with ALS getting into trials. And I've studied the heck out of this, and I think there's several reasons why this happens. So there's actually 3 categories: trial design factors, patient factors, and doctor factors. Under trial design factors, I think the most important thing is that our trials often have inclusion criteria that are too narrow. In other words, we only want people in the first 2 years of their ALS who have a forced vital capacity of greater than 70%, who are not using BiPAP, don't have a feeding tube, don't have a diaphragm pacer. It excludes a lot of people. Why do we do that? Because we're looking for very small signals in a very noisy disease. And as a result, we have to try to homogenize patients as much as we can at the start. Very often we're looking, the signal that we're trying to find is a 10% slowing in the rate of progression of ALS. That's a small signal, and I showed you how noisy the disease is. Doctor factors. Well, as we talked about before, not all doctors are the same, and there's some doctors that don't make it a point to talk to every patient about research every time. And that's got to change. And then finally, there are patient factors as well. So a very real problem with a lot of our trials is they're very burdensome. They last a long time. There's a lot of visits. They're long visits. We ask you to do lots of stuff. And that's not easy, especially as the ALS progresses and it gets harder to travel. It's a lot to ask. Many patients don't want to go into a trial where there might be a placebo. They might only get one chance to do a trial in the course of their disease, and they just don't want to take that chance. And then I've heard from many patients that they're frustrated that trials take too long to get an answer. So you can imagine if we had a year-long trial and we wanted 500 people to be in the trial, and between the time that the first person was enrolled and the last person was enrolled, that was a year and a half. So now that last person's got to go for a year. So now we're talking about 2.5 years that it takes just to do the study, and then probably another 6 months to analyze all the results and get them out. So from the time that that study starts until the time that a person gets answers, that can be 3 years. Well, that's the lifespan of 50% of people with ALS. That's just way too long. So what can we do about this? Well, I think we have control over some of these things. And so I'm actually going to try in this R.O.A.R program to design the most patient-friendly study in history. So I'm going to design a study that has very broad inclusion criteria. Almost everybody with ALS can be in this study. How can I get away with that? Because I'm looking for a huge effect. I'm actually looking for an ALS reversal. It's the biggest effect anyone's ever looked for. Now, there's a good chance this is going to fail, right? And at the end of the day, when this is done, somebody could raise their hand and say, well, but you might have missed a small effect. You're right. So you can't have it all. If you want to look for a big effect, you can do this. But the downside is you might miss a small one. This trial is not going to have a placebo. So we're going to use historical controls. We're going to match people to folks who appear to have the same amount of progression before the study starts. And that's how we're going to figure out if this did anything. There's going to be very few face-to-face visits in this trial, only 3 face-to-face visits over 12 months. Most of the visits in this trial are going to be done by patients at home using their own measurements on their own computer. So we're going to teach people who come into this trial how to measure things and how to enter their data in the computer themselves so they don't have to keep coming in. And then finally, anybody that's interested in knowing what's going on with this trial will be able to look at it at any time and see exactly what's happening. The results are going to be available in real time. How are we going to accomplish all that? By partnering with a group called Patients Like Me. So Patients Like Me is an online community of folks with rare diseases. And there's a whole bunch of parts to it. So you can create a profile and tell folks about yourself, how old you are, where you're from, what other kind of conditions you have, what your ALS looks like. And you can also monitor yourself including monitoring the treatments that you're taking, as well as the measurements that you or your doctors make, including the ALS FRS. You can input this yourself. So right now there are 7,000 patients with ALS that are registered on Patients Like Me, which is amazing. And there's a lot of good things we can do with this data. So with ALS Untangled, if I'm interested in knowing how people are doing on a particular alternative treatment, I can go on there and search that treatment. So for example, when I wanted to know about coconut oil, I go on the website, I plug in coconut oil, and I can see that there's 28 patients that are taking coconut oil for ALS. 12 of them have completed evaluations, and I can go in there and find out exactly what those 12 people are saying about this particular thing. This can also be used for even higher level research. So a few years ago, the ALS world was very excited about the drug lithium. So there was a report that came out from Italy. A doctor there had a theory about the use of lithium in ALS, and he gave it to some of his patients. 16 patients got it, 28 patients didn't, and he followed those patients along for 15 months. And what he found was that none of the patients on lithium progressed, and all the patients who weren't on lithium progressed dramatically. And we had never seen results like that with any drug before, so everybody in the ALS world dropped everything and started studying lithium. 5 different clinical trials were undertaken. It took over a year to get the trials done and get results out. In the meantime, of course, many patients just went to their doctors and asked if they could start taking lithium, and did, and entered their data on Patients Like Me. Patients Like Me did a study where they took all those folks who were taking lithium, made a matched historical control, and figured out what happened. And what they were able to show in a very short period of time is lithium didn't seem to do anything. And a year later, when we all published our trials, we found the same thing. So this is a new way to do research. It might be a little faster than the old way, and it allows people to look at things in more real time. So this R.O.A.R Lunasin study, we've got 5 hypotheses. We're going to see if we can make more ALS reversals, or at least dramatically cut the rate of progression of the people with ALS. We're going to actually do a biomarker study to see if Lunasin can alter histone acetylation like the company says it can. We're going to see if patients can be taught to accurately measure their own ALS functional rating scale. We're going to see if people can accurately measure their weight over the course of the study, even as they might become more disabled. We're going to see if this new design is associated with faster enrollment compared to more traditional designs, and also if it's associated with lower dropout. So 50 patients, widely inclusive. Those are the inclusion criteria. They're in your binder. It's 12 months, 3 face-to-face visits, 12 virtual visits, and then some calls from the coordinator. Other things that we're doing to try to address enrollment, well, we've created a lot of new websites that talk about clinical trials. The Northeast ALS Consortium has a trial concierge. So if you're trying to find a trial, there's a place on their website where you can talk to somebody or email somebody, and they'll help you find a trial. We've got a lot of new ALS clinics around the country. We've got a lot of new educational materials. We already talked about ALS Untangled, and I briefly mentioned this program, the Clinical Research Learning Institute, where we're training patients and families to really understand research, understand why we're having problems enrolling, and to go out and educate other patients and families about research. In the meantime, as we slowly make our way over these 6 traditional barriers to a cure, there's an explosion of clinical trials going on. We've never had this many clinical trials that have either just finished, are going on, or are about to start. And a lot of that is because of all the ice bucket money. So I'm not going to go through all these clinical trials, but you can see in your binder that there's a huge number. I've never seen this many in 15 years at one time. So just to summarize, there's 6 specific reasons that I think we don't have a cure for ALS. And we're on the cusp of finally being able to get through these, finally understanding why ALS is happening to people, how we can identify subtypes of ALS, how progression occurs, how we can diagnose and follow patients more efficiently, and how to optimize enrollment. In the meantime, a huge number of trials are underway, and I am very excited about the next few years in this field. So again, I'll just end by thanking patients and families. Again, you're our inspiration. You participate in these studies, and through your ice bucket money, you're even funding these. as well as other funding agencies. People who fund my work are ALSA and the LVH ALS Foundation. And then finally, my colleagues, especially those at MGH, who helped me make a lot of these slides. Thanks, and I'll be happy to take questions. Yes, ma'am.
It's more of a statement. I'm a nurse in the ALS clinic, and a lot of the trials are so far. There's such a distance, either financially, physically, people who have kids with trials, where they come in and they don't fit the criteria. How would they become involved with the R.O.A.R? Just by going on patients like me, or is there more to it than that?
So there's two ways they could get involved in that Lunasin stuff. So if they want to be in my R.O.A.R Lunasin study, they can email me, and I'll put them on the list. My coordinator's keeping a list of who wants to be in that. Right now, that study is just waiting for IRB approval before we can start enrolling patients. But again, you'd have to actually be willing to come to do 3 times over 12 months. We do have to have those 3 face-to-face visits, because at some point we do have to check to make sure that patients are accurately able to record these things. We don't know that they can do it. We think so, but we don't know for sure. And if they can, this might be a new design for pilot trials in the future, period. It's much more resource efficient for one thing too. The other is, they can take Lunasin. Lunasin's available over the counter. So once my protocol gets IRB approved, I'm actually going to publish the protocol on the website ALS Reversals. So anybody that wants to follow along at home can read exactly what we're doing, and including signing up for an account on patients like me and tracking their own outcome measures exactly like we're doing in the study. And then when we're all done, we plan to not only analyze the people who are in the Duke R.O.A.R study, but also do a separate analysis of everybody else that's taken Lunasin according to the same protocol, and see if there's any difference.
Do you have another question?
Sure.
Thanks for the wonderful update. I have a question coming from the perspective of a provider.
Yeah.
Given the genetic revolution, how should we actually utilize this information outside of research? How should we utilize the genetics in treating our patients and managing our patients?
Yeah.
And actually, a second question, what do you think about GM6?
Sure. So 2 excellent questions. So as far as genetics go, I may still be in the minority, and that is I offer genetic testing to every patient that I diagnose with ALS. And I explain to them, these are some reasons that you might want to consider it. First of all, most people who get diagnosed with this want to know everything they can about it, including, if possible, why it happened. If I don't do this test, the chances are I'll never be able to tell you that. Second, most people want to know, are there other family members at risk? Most of the time, the answer to that is probably not. But if we do the genetic testing, we can make a more scientific statement about the risk to family members. Third, many times people want to know, with as much accuracy as possible, how am I going to progress? How fast? What other kind of things might happen to me? Like, will I get dementia? Those kind of things. Genetic information really helps me give you a more accurate prognosis. And then finally, people want to be prepared for when the most exciting research studies pop open. And again, I think the most exciting research studies that are going to happen in the next few years are these genetic ones, where we're actually able to turn off bad genes. And so if one of those opens, I want all my patients to be ready and to be able to get over there and sign up, because I really think that's going to be the most dramatic thing that we've ever tested. So I'd hate to have somebody miss out because they weren't sure they wanted genetic testing, and then the study opens and it takes a few months to actually get it, and by the time we get it, the study's already closed, already full. So that's how I use that information. Now, the downside to genetic testing, there's a few. I mean, one is if we do it and it comes back positive, I mean, now family members do have to consider the possibility that they may be at risk, but I always think more information is better. Second, there's a cost to it. Most insurance companies don't pay for it. The good news is, as the cost has come down for research, it's also come down for clinical testing. So there's a company called Prevention Genetics that offers testing for C9orf72 that only costs $250. And when patients ask me, well, how would you suggest we do the genetic testing? I say, well, let's test that gene first, because that one's so much more common than anything else. If it comes back positive, we're done. If it comes back negative, we can talk about whether we want to do all the rest of the genes. There's a second company, I think it's called Neurology or Neurology, and they will test the other 26 genes, they use a chip, and it's $1,500 out of pocket. But this is 6 months ago. To do these same two tests for C9orf 6 months ago was $1,500, and for a panel of just 9 genes, it was $10,000 out of pocket. So the cost is just plummeting. So that's my take on genetic testing. And then when it comes to the subject of GM6, also known as GM604, so this is a motor neuron growth factor, which is a so-called master regulator during development. It affects a lot of different pathways that are probably important to motor neurons, so the mechanism is certainly plausible and interesting. The data, the only place that the data is currently available is on the blog of the company, Genervon. The data has not been presented at a meeting. The data has not been published anywhere. So I'll tell you what it says on the blog. It says that they did a very small study, which was 12 patients. 8 patients got GM604, 4 patients did not. They got placebo. These patients were treated for 2 weeks and then followed for an additional 10 weeks. And 7 out of 8 patients who got the drug did not progress. All 4 of the patients who didn't did progress for 12 weeks. So I'll say, and the other point about all that is that it seemed like nobody had any serious adverse events. So the great news is it seems to be safe and tolerated, at least when given for 2 weeks and followed for an additional 10. That's what you're trying to learn from a study like that. A very small first ever exposure in a patient with a disease. You're just trying to make sure people don't explode when you give it to them. Because now you've got enough information to do a larger study, right? So I think that was great. We definitely have enough to do a larger study. Now, much has been made out of the fact that 7 out of 8 people didn't progress. Well, the natural history studies that I've done in PROACT for my ALS Reversals program suggest that 12 weeks of stable ALS functional rating scale is pretty darn common. It's just the natural history of the disease. So I don't think we can look at that and say for sure that this drug works. I mean, if 12 people got better, had an ALS reversal, that would be very unusual. But the majority of people in the PROACT database would have a 12-week period where they didn't progress. So that efficacy signal is not all that impressive. The other interesting thing that came out of this is what the company decided to do with the results. So the company decided, rather than go ahead and start a second trial, decided to go right to the FDA and try to get what's called accelerated approval. So, there was a lot of buzz on the internet. There were 500,000 people that signed a petition to the FDA that said, we want accelerated approval of GM6 based on this data. So there's really sort of 2 issues there. One, should the FDA approve a drug like that? And 2, should patients be allowed to take it? The answer to the first question, in my opinion, is no. FDA approval means something. It's important to society that there be a governing body where people look at data and say, yes, we do think there's a very good chance that this works and a very low chance of it hurting people. And there's no way anyone can do that with a study like the one I described to you. It just can't be done. The bar can't be met. The second question, should people be allowed to take it? Absolutely. And the funny thing is that the 500,000 people that signed the petition, they're mad at the FDA because they think the FDA is the group that's keeping them from taking it. It's not. The FDA has a pathway for patients who want to take anything. So a person with ALS can take anything they want as far as the FDA is concerned. They have something called expanded access. So a doctor and a patient can get together and they can say, hey, you like GM604? I think it's interesting too, but there's one more player that's got to be involved, the company. The company has to agree to sell the patient that drug. As long as those 3 parties are all in agreement, they can apply to the FDA and the FDA will say, fine, go ahead and do it. Just make sure you send us any kind of serious adverse events that you run into. But that's all on the FDA website. So in my opinion, the people that kept patients from taking GM6 were not the FDA, it was the company. The company came right out and said they weren't doing any expanded access. So long-winded answer to an important question. Thank you.
We are going to make the last question. Just lunch is ready, so lunch is being served right outside these doors. There's a buffet and it runs on both sides. And we just ask once you get your lunch to come on back in the room for our afternoon or for our lunch speaker. A reminder, there restrooms are right out this door to the left or down the hall to the right. And once again, thank you to our vendors and Dr. Bedlack for this morning's presentations.